Hello friends, today we will continue the unit 2 pharmacology of drugs acting on cardiovascular system. In this unit we have started the chapter 1, that is drug used in the therapy of shock. We studied the part 2 of this chapter. In that we discussed about the types of the shock. So today in this third part of this chapter we will study about the detailed description of the type of shock, therapy of that individual type of the shock, and the monitoring of the patient during the therapy of that individual type of the shock, and the drugs used in that individual kind of the shock. So let us start the topic with the first type of shock, that is hypovolemic shock, which is the most common type of the shock. As name suggests, hypo means less or decreased. Volume means related with that of the volume. This decrease in optimum volume of the fluid is responsible for the shock is considered as a hypovolemic shock. Actually, what happens? This decreased intravascular volume, either by severe loss of the blood or inadequate fluid intake, is mainly responsible for improper tissue perfusion. If there is improper tissue perfusion, we can consider it or called as the hypoperfusion. And that hypoperfusion is responsible for the shock condition. So this hypoperfusion takes place here due to the decrease in the volume. So this kind of the shock is related with that of the fluid. So there are the causes of the hypovolemic shock. So here I summarize three shock kind of the causes. Number one, hemorrhage or the acute blood loss. Number two, burn, also responsible for the decrease in the volume or responsible for the volume hypovolemic shock. And the third is excessive vomiting and diarrhea is the another cause is responsible for the decrease in the volume, loss of the fluid. So it is also a major cause of the hypovolemic shock. Now this hypovolemic shock is classified into the four classes on the main basis of blood loss and percent of blood volume loss. They are classified into class 1, class 2, class 3 and class 4. With this, additional parameters are also monitored like pulse, pulse pressure, respiratory rate, urine output and mental status. So according to the class of this hypovolemic shock, we implement the different kind of therapy to overcome this shock state. Actually, treatment revolves around controlling loss of fluid and blood, replacing what's been lost, and stabilizing damage that both caused and resulting from the hypovolemic shock, like blood plasma transfusion, platelet transfusion, red blood cell transfusion, and intravenous crystalloids. Another important key point during the therapy, that is systolic blood pressure of their blood will be 100 mmHg or lower. Their heart rate will increase to over 120 beat per minute. They will have a rapid breathing rate of over 30 breaths per minute. They will begin to experience mental stress, including anxiety and agitation. Then, another important key point is the urinary output. The normal urinary output in adult is 0.5 ml per kg per hour or more, equivalent to about 30 to 50 ml per hour for most adults. Any abnormalities in urine output should prompt assessment of the adequacy of circulating blood volume, cardiac output, and blood pressure. These should be corrected in adequate manner. Here I am discussing in short. For example, class 1, there is a blood loss 70 ml and percent of the blood volume, that is 15%. Pulse is the less than 100, blood pressure normal, pulse pressure normal, respiratory rate 14 to 20. And here already we discussed about the urinary output is greater than 30. And mental status is slightly anxious, and here we are giving the treatment with the fluid crystalloids. Then come to the next point, that is pathophysiology of hypovolemic shock. Here this hypovolemia is responsible for the decrease in venous rate, which is further responsible for the decrease in the preload. Means this condition is responsible for the decrease in cardiac output. And what is cardiac output? That is the SV into HR. Systolic volume into the heart rate is equal to called as the cardiac output. The decreased cardiac output is responsible for the condition of hypotension. This hypotensive condition due to hypovolemia is finally responsible for the perfusion failure and tissue hypoxia. There is a less supply of the oxygen to the tissue. It fails, this condition fails to fulfill the biological oxygen demands. So finally what happens? There is a organ dysfunctioning, and this organ dysfunctioning leads to the multi-organ failure that we already discussed what happens in due to the multi-organ failure. Now after the class of the hypovolemic shock and the pathophysiology, let us concentrate over the severity of the shock. The severity of the shock is further divided into the three conditions: mild, moderate, and severe. Mild condition, that means less than 20% of the blood volume loss. In a moderate, 20 to 40%, and in severe, more than the 40% blood volume loss is there. It decides the severity of the shock, and the severity of the shock is further monitored by some of the features, like in case of the mild, we will see the cool extremities, increased capillary refill time, diaphoresis, collapsed veins, and anxiety. In case of the moderate, same pulse, tachycardia, tachypnea, oliguria, postural changes. But in case of this severe condition, hemodynamic instability is there, marked tachycardia. So noted this point, marked tachycardia is there and hypotension is there, and mental status is deterioration, means the coma. Now, after this pathophysiology and severity, come to the main point, that is the management of hypovolemic shock. Initially, the management of the hypovolemic shock involves the physical examination. In the physical examination, the ABCs are the priority. So, what is ABC? It is the algorithm was initially designed and implemented for requiring cardiac pulmonary resuscitation. Here, what is the meaning of this ABC in this algorithm? A means what? Airway disorder with C spine control, and B breathing disorder, and C is circulation or cardiovascular disorder. Further, the neurologic exam reflects cerebral perfusion. This neurological examination reflects the cerebral perfusion. How much cerebral perfusion is there, either it is normal or abnormal. Then we will approach the vascular access to manage this hypovolemic shock. So, how we will assess this vascular system? First, at least 2 to 16 or larger gauge needle in upper extremities we are using. Then, should not be placed in an injured extremities. This we have to take care during the vascular access. Then, if peripheral lines cannot be established, so femoral or saphenous vein may be used for the rapid infusion to treat this hypovolemic shock in the initial management. Then, subclavian and internal jugular vein are useful for CVP monitoring. So here the question arises, why we are monitoring from CVP, and what is this CVP? Actually, CVP is central venous pressure. Is the pressure measured in the central vein close to the heart. It indicates mean right atrial pressure and is frequently used as an estimate of right ventricular preload. That we already studied in the pathophysiology, how preload is responsible in this hypovolemic shock. The CVP does not measure the blood volume directly, although it is often used to estimate this. So, in the initial management of hypovolemic shock by the fluid therapy, what we should and what we should not. First, a rapid infusion of either isotonic saline or ringer lactate should be started. Then take care to avoid hyperchloremic acidosis from loss of bicarbonate buffering capacity and replacement with excess chloride. Then ringer lactate should be avoided in hypokalemia and renal dysfunction. Do note this point, this is very important, that in hyperkalemia and renal dysfunction we should avoid ringer lactate. Then infusion of 2 to 3 liter fluid over 20 to 30 minutes should restore normal hemodynamic parameters. In case if this infusion of 2 to 3 liter over 20 to 30 minutes fails to restore the normal hemodynamic parameter, then we have to follow the different therapeutic guidelines as per the condition of patient. Later I am discussing about the same. Now, in continuation to previous discussion, if infusion fails to restore normal hemodynamic parameters, then what therapeutic step we should follow? Here I mention the guideline in the flowchart. Suppose fluid replacement in hypodynamic shock, we are initiating IV therapy 6 ml per kg per hour by the crystalloid for 1 to 2 hours. So there are the two chances. If improvement will be there, if no improvement will be there. If improvement is there, then reduce the intravenous fluid to 3 ml per kg per hour for 6 to 12 hours. Further improvement is there, then discontinue after 24 hours. But in case if there is no improvement, then we should increase the intravenous fluid 10 ml per kg per hour for 2 hours. Then in this case also there are two chances. If improvement is there, then reduce to 6 ml per kg per hour, 3 ml per kg per hour, discontinue after 24 hours. If improvement still is not there, then hematocytrate rise, IV colloid 10 ml per kg per hour, means we have to give. If hematocrit falls, then blood transfusion we have to do 10 ml per kg per hour. Like this, we have to follow this therapeutic guideline if we are doing infusion through the fluid replacement in the treatment of hypovolemic shock. Now, let us discuss the advantages and the disadvantages of colloids and crystals. And we will see here the comparison of colloids and the crystalloids. First, have a look on colloids and the advantages of the colloids. The colloids are less fluid required, more volume remaining vascular space, potential to draw fluid into vascular space. And the disadvantages of the colloids are expensive, potential for allergic reactions. Note this point, potential for allergic reactions is a major disadvantage of colloid. And coagulopathies and the seizures. The example of colloids are albumin, hetastarch, pentastarch and dextran. On another hand, the crystalloids, the advantages of crystalloids are less volume needed, stays in intravascular space better, draws intestinal fluid, increases cardiac output and minimum atrial pressure, inotrope, decreases SVR due to the vasodilation of precapillary vessels as a result of osmolarity. Then the disadvantages of the crystalloids: hypernatremia, hyperosmolarity, seizures, coagulopathy, Here, the advantages of the crystalloid is the decrease of SVR, that is due to the vasodilation. Actually, what happens when blood vessel constricts, vasoconstriction is there, this leads to an increase in SVR, that is the systemic vascular resistance. And when blood vessel dilate, vasodilation, this leads to decrease in the systemic vascular resistance. And another disadvantage is anaphylactoid reaction with dextron added. Now, come to the point, monitoring the response. What type of the responses we have to monitor during the therapy of shock? BP, pulse pressure, heart rate, skin, and the level of consciousness. And in addition to this, urinary output is the best parameter as we discussed earlier. And another key parameter is the acid-base balance. On the basis of the shock, the acid-base balance are monitored. For example, in early shock, the respiratory alkalosis due to hyperventilation. In case of middle shock, mild metabolic acidosis is there. And in case of the late shock, severe metabolic acidosis due to inadequate tissue perfusion is there. Now, the lactate level and base deficit have been suggested as the best laboratory parameter to monitor the hypovolemic shock resuscitation. Through so many experiences and the case evidence based, the practitioners have experienced that this base deficit parameter mainly monitored for the hypovolemic shock. So what is this base deficit parameter? It is the amount of base required to be added to neutralize the pH, and normally it is greater than -2 millimolar per liter. A base deficit indicates an excess of acid. It refers to the amount of base needed to titrate a serum pH back to normal. Healthy human arterial blood pH varies between 7.35 and 7.45. Then, in parallel to monitoring the response, we must consider some specific considerations also during the therapy, like equating BP with the cardiac output. An increase in blood pressure does not necessarily mean an increase in cardiac output, because increased systemic vascular resistance can increase the BP without increasing cardiac output. So this specification must be considered. In case of elderly, reduced catecholamine response and medication responses, pre-existing hypovolemia, reduced cardiac function, and other physiological results like lungs, kidney is also get reduced in elderly. In case of athletes, may not have tachycardia, and in case of the pregnancy, there it is itself a hypervolemic state. So medication preventing response is there, for like beta blocker, calcium channel blockers, and the diuretics. Now come to the class of the drugs used for the therapy of shock. Mainly, the drugs used for the therapy of shock is classified into the four main categories, out of which the first class of the drug is called as the inotropes. So, inotropes are those agents which are having the capability to change the myocardial contractility. And the second class of the drug is called as the vasopressors. So vasopressors are the agents having the potency to increase the blood pressure. And the third is called as the chronotropes. Chronotropes are an agent which are having the capability or the potency to change the heart rate. And the fourth category of the drugs are called as the dromotropes. Dromotropes are those agents which are having the potency to increase the cardiac conduction velocity. Then come to the drug norepinephrine. Norepinephrine is most widely used vasopressor and it's a potent alpha 1 agonist responsible for vasoconstriction in the tissue bed. And resultant increase in the systemic ventricular resistance causes rise in the blood pressure. So the action of norepinephrine as summarized over here, alpha 1 stimulation is responsible for the vasoconstriction, and due to the vasoconstriction, increased systemic ventricular resistance is there, due to which the increase in mean arterial pressure. And the another key point is due to its beta 1 effect, the positive chronotropic effect is there, that is the increase in the myocardial contractility. And the standard dose of norepinephrine is 4 mg in 50 ml. The second drug of choice to treat the shock is epinephrine. Epinephrine is called as the niches vasopressor. It is the most commonly used during resuscitation, cardiac arrest, and anaphylaxis. Its alpha 1 activity increases the systemic ventricular resistance. So beta 1 activity increases the heart rate and myocardial contractility, whereas the beta 2 effect is responsible for the bronchial smooth muscle relaxation, bronchodilation, and the standard dose is 10 mg in 50 ml. So the third drug of choice is dopamine. It is a vasopressor agent mainly used in cardiogenic and septic shock, but the main feature of this drug is that its receptor stimulation depend on the dose given. For example, if you will give the low dose, it will work on dopamine 1 receptor is responsible for the increase in renal perfusion, whereas the medium dose mainly act on the beta 1 receptor responsible for the increase in cardiac output, whereas the high dose alpha 1 and it shows the vasoconstriction and increase in the pulmonary vascular resistance. And the standard dose of dopamine is 2 to 1 mg, 0.2 to 1 mg per unit. Next choice of the drug is dobutamine. Dobutamine is a synthetic catecholamine. It's an inodilator. Its beta-1 stimulation increases heart rate and increase cardiac contractility, and its beta-2 action mediates the vasodilation. And the reduction in mean arterial pressure is common with the use of this drug dobutamine. And due to its overactivity with that of the beta-2 mediates the vasodilation, sometimes norepinephrine usually needed to offset the vasodilation effect. And the standard dose of dobutamine is 250 mg in 50 ml, or we can say 5 mg per ml. Another choice of the drug is the vasopressin. Vasopressin is a peptide hormone released from the posterior pituitary. Actually, vasopressin causes the increase in the permeability of distal convoluted tubule and the convoluted tubule, so that it increases water retention through the vasopressin 2 receptor, whereas through the vasopressin 1 receptor, which is present in the smooth muscle of the arterial wall, and its stimulation causes the smooth muscle contraction. So it is responsible for the vasoconstriction through the vasopressin 1 receptor. Here I summarize in this flow chart that arginine vasopressin released, if it act on vasopressin 1 receptor, is responsible for increase in systemic vascular resistance. If it act on the vasopressin 2 receptor, it is responsible for increase in the blood volume through the water retention by the kidney. So by both of these routes it is responsible for increase in the arterial pressure, and normally it is used to augment the norepinephrine action, used in case of those who all are inotrope resistant. In the inotrope resistant shock, we are using it. Its dose is 60 unit in 60 ml of 0.9% NaCl or 2.4 ml per hour at a fixed rate. So we will continue the fourth part of same topic. Till that, have a nice day. Thank you.